Hello students, I'm Dr. Manisha Buddhiraja, your faculty for ENT, and today we will be doing the ENT recall questions of the November INI-CET 2023. So in ENT, we had a total of 12 questions, out of which 5 were from the year. And as you can see, the topics are all of them the most favorite of INI-CET. In fact, at the end of the video, I will also tell you what are the frequently asked favorite topics of INI-CET from each of the sections, so that you can make sure that you thoroughly revise those topics before you go for the upcoming INI-CET. So from the anatomy, we had 2 questions, audiology 2 and Meniere's 1. From the nose section, we had total of 4 questions, 1 each from rhinosporidiosis, fungal sinusitis, complication of sinusitis and tumors of the nose. From the pharynx, this time we did not have any question. From the larynx, we had 3 questions, 2 from anatomy and 1 from foreign body. So now let us start. Yes, first from the ear section. So the first question we have here is, which of the following statements are correct about the hair cells of the organ of Corti? So what is being asked is the correct statement. So the first choice, there is 1 row of inner hair cells and 3 rows of outer hair cells. Is that true? Yes, so here we have a cut section of the organ of Corti where we are seeing the scala media, and in the scala media we know the lower membrane is the basilar membrane on which is present the sensory end organ of hearing, the organ of Corti. The inner hair cell are present towards the inner side, that is towards the modulus, so they are known as inner hair cell, whereas the outer hair cells are present towards the outer side, that is towards the stria vascularis, so they are known as outer hair cells. And as we can see here, the inner hair cell is a single row of cell. It is a single row of cell, whereas the outer hair cells are arranged in 3 rows. So yes, the outer hair cells are much more in number. And if we talk about the numbers, then to be more appropriate, the number of the inner hair cell is around 3,500 in number, whereas the outer hair cells are approximately 12,000 in number. So yes, this is the correct choice. This is true. The inner hair cells are responsible for transmitting auditory impulses. Is that true? So yes, so on the inner hair cells are mainly the afferent nerves. These afferent nerves carry the auditory impulses to the brain, whereas from the brain start the efferent nerves, which come on mainly on the outer hair cells. So the main function of the inner hair cells is to transmit the auditory impulses to the brain, whereas the main function of the outer hair cells is to modulate the function of the inner hair cells. How that happens, we'll just see in a while. So yes, this is also true. Majority of the afferent fibers of the spiral ganglion supply the inner hair cells. Is that true? Yes, we just saw that majority of the afferent are on the inner hair cells and efferent on the outer hair cells. And can you tell me what's the spiral ganglion? Yes, that is the ganglion of the cochlear nerve. So this is also true. The outer hair cells primarily initiate the electrical signals sent to the brain in response to sound vibrations. What do you think? Yes, this is false. It is the inner hair cells which primarily initiate the electrical signals. So this is false. So 1, 2, and 3 are true. So the answer is B. Okay, so now that they have asked you about the hair cells of the organ of Corti, it is likely that in the upcoming INI-CET, they will be asking you more similar questions. So let us quickly summarize what we have already done. And then I also want you to know some more points about the hair cells of the organ of Corti. So summarizing what we have already done, in the organ of Corti, we have the hair cells. They are the primary receptors of hearing, right? So this is another question that is asked. The primary receptor of hearing are the hair cells. And the hair cells of the organ of Corti are 2 types, inner hair cells and outer hair cells. Yes, we have seen that the outer hair cells are much more in number. The ratio is 1:3. The inner hair cells are flower-shaped, whereas the outer hair cells are cylindrical. And on the inner hair cells, we mainly have the afferent, which are responsible for transmitting the auditory stimuli, whereas on the outer hair cells, we mainly have the efferent, which modulate the function of the inner hair cells. Now, along with these hair cells, in the organ of Corti, we also have supporting cells. So what do these supporting cells do? They are present around the hair cells and they give mechanical support to the hair cells. Yes, we need to know their names. They are the cells of Dieters, the cells of Hansen, the cells of Claudius, and we have the cells of Butcher. Yes, so these are. So now I also want you to know how the functioning of the organ of Corti hair cells occurs. Yes, that is important. You need to know for the upcoming exam. Yes, so can you tell me what's the function of the organ of Corti? Yes, the organ of Corti is present in the inner ear, and that is responsible for transduction of sound. What's the meaning of transduction of sound? Transduction of sound means that the sound impulses are getting converted to electrical impulses. In other words, the mechanical energy of the sound waves gets converted to electrical energy. So how does that happen? Let us see, right? So whenever there is any sound that reaches the tympanic membrane, it gets transmitted through the ossicular chain to the footplate of stapes, which is present on the oval window. So now from the oval window, the sound will go into the inner ear. Can you exactly tell me where in the inner ear? Yes, in other words, the oval window connects the middle ear to which part of inner ear? Yes, a very, very important question. How did I tell you to remember that? The V of oval tells you that it connects the middle ear to V of vestibule, and that in turn is connected to the V of scala vestibuli. Right? So from the oval window, the sound vibrations will now go into the vestibule and then to the scala vestibuli. Now, this is a simplified diagram where we are not seeing the vestibule, we are directly seeing the scala vestibuli. So now the sound vibrations will go in the scala vestibuli in this direction. And at the helicotrema, which is the connection between the scala vestibuli and the scala tympani, present at the apex of the cochlea, the sound vibrations will now go into the scala tympani in the reverse direction, and the round window will move out. So this opposite movement creates a shearing action in between. And what is present in between? Yes, in between we have the scala media, in which the lower membrane, the membrane that is present below, B for basilar membrane. So below we have the basilar membrane on which is present the sensory and organ of hearing, the organ of Corti. So this opposite movement creates a shearing action leading to stimulation of the basilar membrane, movement of the basilar membrane, and in turn stimulation of the organ of Corti. So let us see how that happens, right? So now on the basilar membrane here are present the hair cells. So when the basilar membrane moves, mainly there is movement of the outer hair cells. Yes. So now just see here that on the tips of the hair cells, on the tips of the inner hair cell as well as the outer hair cells, there are cilia. They are known as stereocilia. And the stereocilia on the tips of the outer hair cells are in touch with this membrane, which is known as the tectorial membrane. Yes, whereas the tips of the inner hair cells, can you see, they are not in touch with the tectorial membrane. Some students told me that this was another choice in the previous question, that the tips of the outer hair cells, the stereocilia of the outer hair cells, are in touch with the tectorial membrane, whereas the inner hair cells do not contact the tectorial membrane. Is that true statement? Yes, that is true. Yes, so what happens is when the basilar membrane moves, the outer hair cells move along with that. Yes. Now, since the tip is attached to the tectorial membrane, and tectorial membrane is a relatively static membrane, so when the outer hair cells move along with the basilar membrane and tectorial membrane is static, that leads to a shearing between the tips of the outer hair cells, stereocilia, and the tectorial membrane, leading to the deflection of the stereocilia. Right now, when the deflection of the stereocilia of the outer hair cell occurs, that creates a radial flow of endolymph that in turn deflects the stereocilia on the tips of the inner hair cells. Is that clear? Yes. So the basilar membrane movement mainly moves the outer hair cells, and that movement creates the radial flow of endolymph, which in turn deflects the stereocilia of the inner hair cells. Now, when the stereocilia of the inner hair cells, when they get deflected towards the taller stereocilia, the channels which are present on the tip of the inner hair cells open. Now, when they open, there is entry of the potassium into the inner hair cells. That is again another thing that you need to know, that yes, in the scala media, we have endolymph, which has more of potassium. So now once the potassium enters into the inner hair cells, because of this entry, there is opening up of the voltage gated calcium channels which are present in the inner hair cells, leading to the entry of calcium in the inner hair cells. And once the calcium is also entered, that leads to release of the excitatory neurotransmitter from the inner hair cells into the synaptic junctions. And that was another question, that what is the excitatory neurotransmitter that is released by the inner hair cells? Can you tell me? Yes, that is glutamate. Yes. So now it is picked up by the afferent nerves, and now the auditory impulses are transmitted to the brain. Now, the efferent nerves, they start from the brain and they come on the outer hair cells. Now, please note here that the outer hair cells have a very special characteristic. They can increase or decrease in length in response to whatever efferent they have got, stimulus they have got. They can increase and decrease in length. And this increase and decrease in length of the outer hair cells further amplifies the movement of the basilar membrane, and that results in further amplification and fine-tuning of the signal before it reaches the inner hair cell, right? So the outer hair cells in this way are modulating the function of the inner hair cells. So this is very, very important. Let us first summarize what we have done, that the excitatory neurotransmitter is glutamate. The outer hair cells can increase and decrease the length, further amplifying and fine-tuning the signal. Hence, this function of the outer hair cell is what is known as cochlear amplifier. And this is likely potential question of your upcoming exam. Cochlear amplifier is another name for, term given for. It is the function of inner hair cell or the outer hair cell. Yes, that is the function of the outer hair cells, right? The tips of the outer hair cells are in touch with tectorial membrane. So what we are seeing is that a lot of activity is taking place in the outer hair cells, and this activity of the outer hair cells produces a sound. It produces a sound emission which is loud enough that it gets transmitted back from the inner ear into the middle ear, and from the middle ear into the external auditory canal. And this sound emitted from the outer hair cells can be recorded from the external auditory canal by placing a special probe here. And this is what is known as autoacoustic emission. So these sound emissions, acoustic emissions emitted from the activity of the outer hair cells is known as autoacoustic emission, right? It is known as autoacoustic emission, also known as Kemp echoes. And the outer hair cells, yes, they are much more in number, but they are also more prone to damage by noise trauma as well as autotoxic drugs, right? The more prone to damage is the outer hair cells. So whenever we are giving any autotoxic drug to any patient, if we are giving any patient kanamycin, amikacin, we know that they are autotoxic. We need to monitor the hearing of the patient. If at all the outer hair cells are getting damaged, we need to immediately reduce the dose, stop, or maybe change the drug. So how do we manage, how do we monitor it? We monitor it by checking for the autocaustic emission. So if the outer hair cells have started getting damaged, what will happen? The autocaustic emission will be absent. So that will indicate that there is autotoxicity taking place, right? So the autocaustic emission is a very important indicator of early noise trauma as well as early autotoxicity, because the outer hair cells are much earlier damaged by these things than the inner hair cells. So these were some things about the inner and the outer hair cells and the functioning of the organ of Corti that I wanted you to know here. So coming to the next question, which type of synovial joint is seen in the picture? So we can see here, arrow is marked in between the head of the malleus and the body of the incus. And yes, this joint is the saddle joint. Now we have another joint that is in between the incus and the head of the stapes. What joint is this? This is the ball and socket joint. So what the answer here? Yes, it is the saddle joint. Now another important thing I want you to know here is that this area of the junction, the joint between the incus and the stapes head is the area with poorest blood supply, because of which, yes, is a question asked that which is the most common ossicle to get necrosed in middle ear conditions, in middle ear diseases. Yes, the most common is the lenticular process, followed by the long process, right? So if lenticular process is not there, you can mark the long process of incus as the answer, and followed by next is the head of the stapes, right? So the next question, a 32-year-old female presents with progressive bilateral hearing loss, which is more in the right ear. After the initial evaluation, a stepidotomy of the right ear was planned. What might have been the tuning fork test results of the patient? So here we have a 32-year-old female with progressive bilateral hearing loss and a stepidotomy has been planned. So what do you think is the diagnosis? Yes, this is a patient of very good otosclerosis, and everything is fitting into otosclerosis. Yes, it is a 32-year-old female. Yes, it is more common in females, leads to progressive hearing loss, and it is bilateral. Yes, and suppose in this question it was not given that the more defective ear is the right ear, could we still make out that the more defective ear is the right ear? Yes, always remember that stepidotomy is always done in which ear first? In the worst ear first. So even if that was not there, this question tells us that the worst ear is the right ear. And we are supposed to find out the tuning fork test result of the patient, right? So whenever we have to find out tuning fork test result, this is the way, the order that you have to follow. So we will write down the right ear, the left ear, the Rinne's, and the Weber's, right? Okay, so what is the diagnosis that we are having here? The diagnosis of this patient is, this is the patient of bilateral otosclerosis. And we know in otosclerosis, what is the hearing loss? It is a conductive hearing loss. And it is given here that right hearing loss, conductive hearing loss in the right is more than left, right? So now tell me what will be the Rinne's. In conductive hearing loss, Rinne's is? Yes, Rinne's is negative. It is bilateral conductive hearing loss. So Rinne's will be bilaterally negative. Now what will be Weber's? What's the mnemonic of Weber's? How do you have to remember? The mnemonic of Weber's is SOCS. S-O-C-S. What is SOCS? Yes, in sensorineural hearing loss, Weber's is towards the opposite side. So if there's a sensorineural hearing loss of 1 ear, Weber's is towards the opposite side, opposite as the disease, that is the better ear. Better ear, right? Whereas in conductive hearing loss, Weber's is towards the same side. So if there's a conductive hearing loss of 1 ear, Weber's is towards the same side as the disease, that is the worst ear. Yes, that is the worst ear. Right? So here what are we dealing with? Sensorineural conductive. Yes, it is a conductive hearing loss. So Weber's will be towards the worst side. Which is the worst side here? Yes, the worst side is the right ear. So the Weber's will be towards the right. So yes, let us see the choices. Bilateral Rinne's negative, Weber's to the right. Yes, so that is the answer. So again, tuning fork tests are very, very commonly asked, and out of which Rinne's and Weber's are the most commonly asked. So let us quickly see what are the important points that we need to remember. So in Rinne's, the Rinne's can be either positive or it can be negative. And if it is positive, only two things should come to our mind. What are the two things? Yes, if it is positive, either it is a normal ear or it is a sensorineural hearing loss, right? So whenever we see Rinne's positive, only these two things will come to our mind. Similarly, whenever it is Rinne's negative, again, only two things will come to our mind. What two things? Either a conductive hearing loss or a unilateral severe sensorineural hearing loss, right? That is the only things that you need to remember in positive and negative. And what do we need to know in Weber's? That I just told you. The mnemonic of Weber's is SOCS. What is SOCS? That if there is a sensorineural hearing loss, Weber's is towards the opposite side as a disease, that is the better ear. And in conductive hearing loss of one side, Weber's is towards the same side, that is the worst ear. Is that clear? Absolutely clear? Okay. So now you are going to answer these questions for me based on the Rennie's and Weber's, right? So here it is given that there is decreased hearing of the right ear. So it is unilateral hearing loss. 1 year is normal. There is hearing loss only of 1 year. Okay, so tell me the diagnosis. Right ear Rennie's is negative. Weber's is towards the right. So the approach always has to be the same. Always remember this. Whenever tuning fork question is given, you will immediately write it down. Yes, this is the right ear. This is the left ear. This is Rennie's and this is Weber's, right? Rennie's and Weber's. So here what is given is that Rennie's is negative. It is given that this is defective. Right ear, left ear is normal. So Rennie's is negative. So tell me, if it is negative, what two things will come to your mind? Either conductive hearing loss of the right ear or a right severe sensorineural hearing loss, right? Now, Weber's is towards the right. Weber's is towards the right. Now, the moment we see Weber's is towards the right, again, only two things have to come to our mind. If the Weber's is towards the right, it can be either a right conductive hearing loss, because in conductive hearing loss, Weber's is towards the same side. Weber's is towards the same side. Or it can be a left sensorineural hearing loss, because in sensorineural hearing loss, Weber's is towards the opposite side, right? Now it is clearly given that the hearing loss is of the right ear, so this cannot be. So what is the diagnosis? Right conductive hearing loss? Yes, so this is the diagnosis. Is that clear? Okay. Now coming to this next question, right Rennie's is negative and Weber's to the left. Now this you will write down and tell me. Tell me quickly. Yes. So again, how will you write down? Yes, we will write down right, left, Rennie's and Weber's. Okay, and it is clearly given that it is the right ear. Don't miss any information that has been given to you in the question. Okay, so now again, Rennie's is negative in the right ear. So again, two things come to our mind. Which two things? Either a conductive hearing loss of the right ear or a right severe sensorineural hearing loss. Weber's is towards the left. Now, whenever the Weber's is towards the left, again, it can be only two things. It can be either a left conductive hearing loss. In conductive hearing loss, Weber's is towards the same side, or it can be a right sensorineural hearing loss, because in sensorineural hearing loss, Weber's is towards the opposite side. So if the Weber's is towards the left, it can be only these two things. Now, since we are talking about the right ear, which is the defective ear, what is the diagnosis? Right sensorineural hearing loss. Do we have that in our DD? We have 2DD. Yes. So the diagnosis is right severe sensorineural hearing loss. Is that very clear? So this was how you will do whenever it is a unilateral hearing loss given. Now, Weber's can also be helpful whenever there is bilateral conductive hearing loss or bilateral sensorineural hearing loss, which means in both the ears there is conductive hearing loss or in both the ears there is sensorineural hearing loss. In these cases, Weber's can tell us which is the better ear, which is the worst ear. Now, here please note that whenever there is in one ear conductive hearing loss and in the other ear sensorineural hearing loss, tuning fork tests are not valid. They will not suggest you anything. They are not confirmatory. So they are not done in those cases. But yes, if it is bilateral conductive or bilateral sensorineural hearing loss, then it will be helpful, right? So if there is bilateral conductive hearing loss or bilateral sensorineural hearing loss, Weber's will lateralize to one side only if the minimum difference between both the ears is at least 5 decibels. Very, very important, right? Which means that if there is bilateral conductive hearing loss or bilateral sensorineural hearing loss, which is equal in both the ears, then the Weber's will not lateralize. Weber's will be in the center. For the Weber's to lateralize, there has to be a difference in between the hearing of the ears of at least 5 decibel. Is that clear? Okay. So if it is both ear equal hearing, it will be in the center. It will not lateralize. Recently, 2 to 3 years back, was this question given in INI-CET. Patient has bilateral Rennie's negative and the Weber's is in the center. It is not lateralizing. So what is the interpretation? It means there is bilateral conductive hearing loss with equal hearing in both the ears, right? Now, if there is bilateral conductive hearing loss and right ear has more conductive hearing loss, tell me the tuning fork test. Yes, so again, what will be our approach? Right ear, left ear, Rennie's and Weber's, right? So if it is bilateral conductive hearing loss, Rennie's will be negative, and right ear is more defective. Okay, right ear is the worst ear. So in conductive hearing loss, what is the mnemonic of Weber's? We know it is sock. So in conductive hearing loss, Weber's is towards the same side, that is towards the worst ear, right? So the Weber's will be towards the worst ear. Worst ear here is the right ear. And this is exactly what has been asked in the question that we just did. Yes, okay. So now the next question, yes, bilateral sensorineural hearing loss. Right ear has more sensorineural hearing loss. Please tell me what will be the tuning fork test result. Yes, so here again, right ear, left ear, Rinne's, Weber's. Yes, I'm doing it always in this pattern because this is how you have to follow, right? So it is bilateral sensorineural hearing loss. Tell me, Rinne's will be what? Bilaterally? Yes, it will be positive. And right ear has more sensorineural hearing loss. So we know that the mnemonic of Weber's, SO, in sensorineural hearing loss, Weber's is towards the opposite side. It is lateralized towards the better ear. So what is the better ear here? The worst ear is the right ear, better ear is the left ear. So the Weber's will be towards the left. Is that very clear? Yes. So this, only this much, if you know, you will be able to answer many of the clinical questions. Yes. So don't think that many difficult things are expected out of you. These are the basic things. If you know this much, yes, that is very good. So coming to the next question, a 60-year-old man presents to the OPD with a complaint of hearing loss. It is 60-year-old man, hearing loss, and can only hear when words are shouted. What is the degree of his hearing impairment according to WHO? Right? So here we have an elderly who has come to us with hearing loss, and he is hearing only when the words are shouted in his ears, right? Which means he is not hearing a normal conversation. So can you tell me what is the loudness of a normal conversation? Yes, a whisper is 30 decibel. A normal conversation is 60 decibel. And a shout is 90 decibel. We already know that. Yes. So what is given here is the patient is not able to hear the normal conversation. He is able to hear only when shouted, which means definitely his hearing loss is more than 60 decibel. Right. So more than 60 decibel hearing loss falls into which category of WHO? Yes. So as we can see in the question, we can make out roughly by just the 60 decibel that it is a severe hearing loss. But let us confirm more. So yes, according to WHO, the grades of hearing are 4 grades. Up to 25 decibel, we consider the hearing as normal. After that, an increment of 15 decibel changes the grade of hearing to mild. Right? So from 26 to 40 decibel, it becomes mild hearing loss. And after that, every increment of 20 decibel changes the degree of hearing. That is how you have to remember, right? So when from 40 it increases 20 further, that is 41 to 60, the category now becomes moderate. Further increase of 20 decibel, that is 61 to 80, it becomes severe. And 81 to 100, that becomes profound, or more than 81 is profound hearing loss, right? So now we have already seen that whisper is 30 decibel, normal conversation is 60 decibel, and a shout is 90 decibel. So tell me, if somebody has a mild hearing loss means up till 40 decibel, will he be able to hear a whisper sound which has loudness of 30 decibel? No. So which means that a patient of mild hearing loss will not be able to hear whisper, but he will be able to hear only a normal conversation which is 60 decibel. Was that simple to remember? Yes, he will be able to hear normal conversation. Now, if somebody has a moderate hearing loss, which means he has hearing loss up to 60 decibel, will he be able to hear a normal conversation? Normal conversation we know is up to 60 decibel. So no, he will not be able to hear normal conversation. Yes, maybe a little raised voice, more than normal conversation, he will be able to hear. So yes, he will be able to hear raised voice. Now, if it is a severe hearing loss, which is up till 80 decibel, there is hearing loss, will he be able to hear a normal conversation, which is 60 decibel? No. Will he be able to hear a shout? Yes. Shout is 90 decibel, so he will be able to hear only a shout, not normal conversation. So yes, he will be able to hear only when the words are shouted. And somebody who has a profound hearing loss, according to WHO, that is more than 81 decibel, Yes, it can be 81 to 100 decibel. Will he be able to hear a shout also? Shout is 90 decibel. No, he will not even be able to hear a shout. So if you just remember these three, you will be able to find out all these disability. Is that clear? So now coming back to this question, yes, severe hearing loss. And what was severe hearing loss? Severe hearing loss was 61 to 80 decibel. So yes, he has hearing loss more than 60 decibel. So coming to the next question, a woman has tinnitus and hearing loss. Tinnitus and hearing loss with episodic vertigo that lasted 2 to 3 hours each. The pure tone audiogram is shown. What is the likely diagnosis? So here is a woman who has hearing loss also and who has vertigo also, which is lasting for 2 to 3 hours. And what's the audiogram showing us? The audiogram, how do we read the audiogram? Yes, we first mark what is the normal. Up till 25 decibel, the hearing is considered as normal. So in this patient, the right ear is normal. And in the left ear, we are seeing that there is defect only in the low frequencies. Only in the low frequencies. And what's the defect? Is there any AB gap? No, there is no AB gap, which signifies that it's a sensorial hearing loss. So in this patient, in the left ear, there is low frequency sensorineural hearing loss. Okay, so what's the diagnosis? Let us see the choices. It is endolymphatic hydrops. Can it be endolymphatic hydrops? What is that? That is Meniere's. Yes, everything fits into Meniere's. Meniere's patient has both vertigo as well as hearing loss. And yes, the vertigo lasts for more than 20 minutes to 24 hours. Here it is for 2 to 3 hours each. And here in Meniere's, in the early stages, we get low frequencies which are affected. Why? Because which turn is affected? The apical turn is affected. Can it be acoustic neuroma? Acoustic neuroma? How do patients of acoustic neuroma present? Do they present with episodic vertigo lasting for 2 to 3 hours? No. When do we suspect acoustic neuroma? Whenever an elderly comes with unilateral sensorineural hearing loss. Frank vertigo is never there. There can be mild dizziness or mild imbalance, right? So no, it cannot be acoustic neuroma. Autosclerosis. Autosclerosis is bilateral. It is conductive hearing loss. Here it is unilateral sensorineural hearing loss. No. Can it be noise-induced hearing loss? Noise-induced hearing loss. Yes. Why will it have episodic vertigo for 2 to 3 hours? And also in noise-induced hearing loss, yes, there is the PTA which shows a dip. The earliest change is a dip at 4000 hertz, and that is what is known as acoustic dip. Okay, now tell me, I will add two more choices to this. One is vestibular neuritis. Yes. And the other is BPPV. Suppose in the choices we had these two also. Can this patient be a vestibular neuritis patient? Yes or no? What is vestibular neuritis? Yes, it is itis, inflammation of the vestibular nerve. So always remember, vestibular neuritis will be only vestibular involvement, vestibular nerve involvement, only vertigo. It will be an acute onset vertigo, and since it is an inflammation of the vestibular nerve, it will not subside in 2 to 3 hours. The inflammation will take some days to resolve. So it will be a sudden acute onset vertigo lasting for 3 to 7 days. And will there be hearing loss here? No, there will be only vestibular nerve involvement, so only vertigo. So this patient cannot be vestibular neuritis because there is hearing loss also. Now, can it be BPPV? In BPPV also there is episodic vertigo, but does it last for hours? No, it is for seconds, and that is on posture change. Again, in BPPV, only the semicircular canals, the otolith gets dislodged in the semicircular canal, only that is involved. There is no hearing loss. Is that clear? Yes? Okay, so some more things I want you to know here, that whenever there is upsloping audiogram, if just this audiogram is given, yes, last year was this audiogram given, and what you were supposed to answer was, what will be the tuning fork result of this patient? Yes, many a times just this audiogram is given, and what is asked is, what's the diagnosis? So whenever you see upsloping audiogram, we have to think of Meniere's. And yes, if I ask you what will be the tuning fork, will you be able to tell me? Yes, Renee's. How do we write? Right, left, Renee's and Weber's. So we know in this patient, what is the diagnosis? It is a left sensorineural hearing loss, and the right ear is normal. So the right ear is normal, so Rene's will be positive, and left ear is the sensorineural hearing loss, so Rene's will be again, it will be positive, and Weber's will be towards, yes, tell me, if it's a sensorineural hearing loss, Weber's is towards, Weber's is SOCS, SOCS. In sensorineural hearing loss, Weber's is towards the opposite side. The Weber's will be towards the opposite side. So yes, this were the choices. Rene's bilateral positive and Weber's towards the opposite side, towards the right ear. Okay. So now, what's the frequency affected? Now, if this audiogram is given and it is asked that what's the frequency affected, we know that it is low frequency. But if sometimes it is just given that upsloping audiogram, what's the frequency affected? So for that, I will just tell you one how you can remember. So if it is a upsloping, means the slope in front of you is going up. So if the slope in front of you is going up, where are you standing? You are standing here. You're standing low. So if it is an upsloping audiogram that you are seeing, you are standing low, it is a low frequency. And in low frequency audiogram, what is the cochlear turn that is affected? Yes, it is the, tell me, the apex. At the apex, we have the low frequencies. Okay, so now tell me this, what is this? Yes, this is a downsloping audiogram. And what are the conditions where you see this? Again, this audiogram has been given many number of times and in the choices with certain things. So what can be in the choice, which can be the answer? Yes, so before that, if by chance it is just given downsloping audiogram and the audiogram is not given, how will you simply immediately remember it is high frequency or low frequency? So if the slope in front of you is going down, it is downsloping, where are you standing? You're standing high. So it is high frequency, and when you go down the slope, you will fall in the pond, P-O-N-D, right? And that is the mnemonic for the conditions where we see downsloping audiogram. It is seen in presbycusis, that is age-related hearing loss. O is for ototoxicity. N is for noise-induced hearing loss, and D is downsloping, right? And which turn of cochlea is affected? If it is a high frequency is in the, tell me, yes, the basal turn. So yes, in noise-induced hearing loss, we see the downsloping audiogram, but that is later on. The earliest change on the audiogram, again, that has been a question, in noise-induced is a dip at 4000 Hertz, and that is what is known as acoustic dip. A 50-year-old diabetic male was admitted with the diagnosis of COVID-19, okay, based on positive RT-PCR. Due to severe lung involvement, he was treated with methylprednisolone. The patient was readmitted to the hospital due to nasal obstruction, left-sided facial and orbital swelling. In sinus endoscopic surgery, debridement was performed and the specimens were sent to pathology. The following could be seen. Choose the most appropriate diagnosis. So what are we dealing with here? We are here dealing with an elderly male who is immunocompromised because of two things. First, he is a diabetic, and second, he has been given steroid. So right now, what is he developed? He has developed features of sinusitis, rhinosinusitis, along with some facial swelling, along with orbital swelling. So what do you think we are dealing with the patient of? Yes, we are dealing with invasive fungal sinusitis. Yes, which is an opportunistic infection seen in immunocompromised. Yes, so we know that invasive fungal sinusitis can be because of two fungus. It can either be by mucor, that is mucormycosis, or it can be invasive aspergillosis. So do we have these in the choice? Yes, we have aspergillus, we have mucor also. So now let us see what the specimen is showing. It is showing wide ribbon-shaped hyphae, and they are not septate, they are aseptate, and they are branching at right angle. Yes. So yes, we have aseptate hyphae branching at right angle. What is the diagnosis? Yes, very good. That is mucor. How is the slide of appearance of aspergillus? Aspergillus have septate. Yes, they are narrow hyphae and they have septate and they are branching at acute angle. So yes, this one is mucor. Now again, mucor has been, this has been the fourth time consecutively that a question of mucormycosis has been asked in your INI-CET. So yes, let us quickly see what are the important things that we need to know in invasive fungal sinusitis. As I told you, it can be either mucormycosis or it can be invasive aspergillosis. And mucormycosis is caused by rhizopus and mucor, and invasive aspergillosis is by Aspergillus fumigatus. Both of them are invasive, both of them are angioinvasive. What's the meaning of angioinvasive? They invade the endothelium of the blood vessels, so they cause thrombosis. And when there is thrombosis of the blood vessels, that creates ischemia in the surrounding areas, leading to necrosis, which is visible as black necrotic discharge, right? So what is the presentation of the patient? Yes, these patients who have the rhinocerebral mucormycosis or rhinocerebral aspergillosis, they present with features of acute sinusitis. Acute sinusitis, that is nasal obstruction, nasal discharge, facial pain, decreased sense of smell, facial pressure, fullness, anesthesia. So when patient is presenting with acute sinusitis features, in which patients do we think that let us rule out invasive fungal sinusitis? Yes, patients who are immunocompromised, immunosuppressed. So you will take the history of diabetes, of any other suppressed history, yes, of any organ transplantation, on any immunosuppressive drugs, on steroids, yes, on neutropenia patients, yes. So when you do endoscopy, what is suggestive is black necrotic areas. They can be just present in the middle meatus or on the middle turbinate, or it can be extensive involvement of inside the nose or of the skin of the nose, of the paranasal sinuses. There can be also extensive involvement when it goes to the orbit or to the palate or intracranially. And the spread occurs from the nose into these areas. Either the spread is direct or it can occur through angioinvasion or through perineural invasion. That was again another question that was asked recently. So how do we diagnose? So for diagnosis, do we use the nasal biopsy, nasal smear, or do we go for radiological investigations? So always remember, yes, this was another question that was asked recently. So for diagnosis, we always have to go for biopsy, for nasal biopsy, or for smear. The radiological investigations will tell you the extent of involvement. They are very, very important, but they're not for diagnosis per se, right? So they will tell you the extent of involvement. They will tell you also about the how the patient is progressing in the management, the resolution of the infection. But for diagnosis, we have to go for a biopsy. Why? Because in the biopsy, we have to confirm that it is invasive fungal involvement. And second, we also have to find out which fungus. Is it mucormycosis or is it aspergillosis? Why? Because the management of both of these is different. Yes, so the diagnosis is by smear or biopsy. Yes, where if you see ribbon-like aseptate hyphae at right angles, it is mucor, whereas septate at acute angles is aspergillus. And also you might see in POX, angioinvasion and perineural invasion. The radiological investigations are for extent and response to therapy. Usually we get a CT scan done, and if there is intracranial or orbital involvement, we also go for MRI. Right? So how is the management different of both? If it is mucormycosis, then we start the patient immediately on IV liposomal amphotericin B. Management is always threefold. It is the systemic management by IV antifungal, amphotericin B here in mucormycosis. Along with that, we have to go for extensive surgical debridement up till we see the normal tissues. And along with that, we have to manage the underlying immunosuppressive status. Right? Now, if it is invasive aspergillosis, we do not give amphotericin B. We will give voriconazole. Is that clear? Rest of the management, local debridement, as well as the underlying immunosuppression management will remain the same. Is that very clear? Now, for the past 2 years consecutively, the mucormycosis that has been asked in your exam is the one which is not seen in immunocompromised. It is seen in immunocompetent. Which one is that? So yes, mucormycosis can be either rhino-ocular or rhino-oculocerebral. That is the most common. It can be pulmonary, gastrointestinal, disseminated. All these are seen in immunocompromised. The one that is seen in immunocompetent is the cutaneous variant. And here in immunocompetent, always there is a history of injury with a vegetative matter. So when this question was asked in your exam, it was given a young female No history of any immunosuppressive status was given, and it was just given that following history of injury with wooden skin, there is subcutaneous involvement, right? So the route of inoculation is a percutaneous implantation here. So coming to the next question, a farmer presents with unilateral obstruction of the nasal cavity and nasal bleeding. A polypoidal mass with white dots on the surface is found and removed. Biopsy is shown below. What's the likely diagnosis, right? So it's a farmer with nasal obstruction and epistaxis, and on examination, we are seeing a polypoidal mass with white dots. And the biopsy, what is it showing? So yes, it is showing the sporangium with multiple sporangiospores, right? So what is the diagnosis? Let us see the choices. Rhinosporidiosis, rhinoscleroma, inverted papilloma, angiofibroma. What is it? Yes, all the features are going in favor of rhinosporidiosis. Is it seen in farmers? Yes, this is seen usually in farmers or in cattle breeders. Why? Because this is an aquatic protozoa which is present in the cattle, in the dung of cattle, which the patient will get by taking bath in ponds frequented by animals. So these farmers or the cattle breeders, when they take their cattle for giving them a bath, they take bath in the same waters. So that is how they get infected. So yes, always a history of taking bath in pond frequented by animals or a similar history, right, there is some contact with cattle is present. And yes, it will lead to epistaxis along with nasal obstruction. And there it is a red strawberry or a mulberry mass, and that mass has white dots. What are the white dots? They are the sporangia of the protozoa. And the biopsy is also suggestive. So yes, the answer is rhinosporidiosis. So yes, rhinosporidiosis, again, this is consecutively the second time in INI-CET. Last time also rhinosporidiosis was asked, and there the presentation was a South Indian cattle breeder. So yes, this is an aquatic protozoa. This is seen more commonly in South. It is endemic in South India. Earlier, this was considered as a fungus. Now it is an aquatic protozoa. So again, that is something that is very frequently asked from you. What is this? This is an aquatic protozoa, Rhinosporidium seaberi. The patient will get infected by taking bath in ponds frequented by animals, and this does not have some special affinity for the nose, but the patient comes with complaints of the nose, of epistaxis, nasal obstruction. Why? Yes, so this is by taking bath in infected waters. So wherever there is any abrasion on the lips, on the oral cavity, oropharynx, nose, nasopharynx, nasal cavity, or anywhere on the skin, this can get inhabited, and there can be granulomas. There can be subcutaneous granulomatous nodules also on the skin. Yes, but the patient comes to the ENT OPD usually. Why? Because the granulomas in the nose are very vascular. They lead to nasal obstruction, they lead to epistaxis. Yes, which brings the patient to the ENT OPD, right? The appearance of the mass, this was the picture that was given last year when it was given in your question, is this typical appearance of strawberry or the mulberry mass, and that has white dots. There can be subcutaneous nodules on the skin also, and the biopsy shows sporangium with sporangiospores. And how do you manage this? Again, another thing that you need to know, you will widely excise this mass, and following excision you go for cauterization of the base, and in the post-operative period, to decrease the chance of recurrence, we go for dapsone, right? Okay, so now quickly tell me, can it be also rhinoscleroma? Is the biopsy or the history fitting into rhinoscleroma? Rhinoscleroma is, yes, it is a bacterial granulomatous condition, and here the presentation of the patient is there are granulomas on the external nose that give the nose a hard woody appearance. Later on, there will be, in the initial stage, there is just a lot of crusting. Later on, there is granulomatous appearance of the nose, that is a very hard woody nose, and further later on, there's a lot of deformity of the external nose, that is the cicatricious stage. That is what is known as the Hebra nose. Hebra nose, that is this, yes, or it can be the tapir nose. Yes, and here the biopsy will show the typical, very, very commonly asked. Quickly tell me, biopsy of rhinostroma shows what? Yes, it will show muculic cells and Russell bodies. Again, what are muculic cells exactly? You need to know. They are macrophages which contain the phagocytosed bacilli, and this is how they look like. And the Russell bodies are the plasma cells which contain the eosinophilic inclusion bodies, right? the eosinophilic inclusion bodies, all that you are seeing here. Okay, so can you tell me, can it be inverted papilloma? This patient, a farmer with nasal obstruction, epistaxis, and this histopathology. Yes, now inverted papilloma was again another recent question of your INI-CET, where the histopathology and the endoscopic picture was given. It was mentioned elderly male with nasal obstruction, epistaxis, and the picture that was given was this: a papillary appearance of a mass coming from the middle meatus and the histopathology. So yes, whenever you're dealing with an elderly with unilateral nasal obstruction, epistaxis, and a papillary polypoidal mass from the middle meatus, what do we have to think of? Any polypoidal mass in the nose of an elderly, rule out tumor, rule out malignancy. Yes, so and this appearance on histopathology of the epithelium going inside the stroma, that tells you that this is inverted papilloma. It is known as inverted because the epithelium, yes, it instead of growing outside, grows towards the stroma. So yes, that is what you see in inverted papilloma. Can it be angiofibroma? Angiofibroma, the history will change. Tell me what the history will be. It will be, yes, it will be a pubertal male specifically mentioned, and also what will be mentioned will be, yes, the diagnostic features. The diagnostic features are on endoscopy, a red fleshy mass, and yes, here biopsy is not done. For diagnosis, what you go for in angiofibroma? Yes, all this is your revision. Tell me, this is, you go for a CCT, where what you see is the pushing of the posterior wall of antrum anteriorly by this enhancing mass. This is known as the antral sign, or this is known as the Hallman-Miller sign. Biopsy is contraindicated in angiofibroma. Following surgery, if the mass that you've excised, when you go for histopathological examination of that, what you will find in angiofibroma? You will find, as the name, only angio and only fibroma, only blood vessels and only fibrous tissue. So you will see lot of blood vessels enmeshed in fibrous tissue. So the next question, a 7-year-old male presents with progressive bulging of one eye with diminution of vision since 1 day. He has a history of URTI, and on examination, it is seen that he also has nasal congestion with active discharge. The CT scan of PNS is seen. Was a diagnosis. So what are we dealing with? We are dealing with a child who has rhinosinusitis features, nasal congestion, nasal discharge, and along with that has involvement of the eye. So yes, we are dealing with a child of acute rhinosinusitis with some orbital complication. So yes, can you tell me that what is the most common complication of acute rhinosinusitis? Yes, very good. It is orbital complication. And orbital complication occur most commonly following which sinusitis? Most commonly following, yes, following the ethmoid sinusitis. And is it more common in children? Yes, ethmoid sinusitis is the most common sinusitis seen in children, and orbital complication also most commonly follow ethmoid sinusitis. So let us see what the choices are. Sinusitis with preseptal cellulitis, sinusitis with orbital cellulitis, sinusitis with subperiosteal abscess, sinusitis with orbital abscess. So yes, it is sinusitis with some orbital complication. Which complication we have to find out, and for that the CT is given. So let us first orient to the CT. So this is an axial cut section where we are seeing the orbit, and this is the nose, right? So this is the nasal cavity inside. Let me see. Yes, this will be more visible. So we are seeing the nasal cavity here, where this is the anterior ethmoids. This is the area of anterior ethmoid. This is the posterior ethmoid. Right, on the normal side, I will just mark it for you. This is the lamina papyracea. So this is the lamina papyracea, and this is the cone of the orbit that we can see here. Here we can see that just next to the lamina papyracea, the periosteum is raised, that is push the orbit on one side, and also there is, can you make out that there is also protrusion of the orbit? So there is proptosis also. So we can see that there is some collection here. There is some collection here. So yes, that is the abscess, and that is, yes, tell me, the subperiosteal abscess. So it is sinusitis with subperiosteal abscess. Subperiosteal abscess. So yes, we need to know the that the complication of the most common complication of acute sinusitis is orbital, and most commonly it follows ethmoid sinusitis. Most common age is pediatric, it is children, and most common sinusitis in children is also ethmoid sinusitis, right? So the orbital complications following rhinosinusitis are classified by Chandler into 5 groups. So what are these 5 groups? The first is preseptal cellulitis. So what is preseptal cellulitis? Let me orient you to this diagram first, right? So what we are seeing here is exactly what we were seeing the CT there. There's the axial cut section where we can see the nose. We can see the eyelids, that's the orbit. We can see the eyelid here. When we go inside the nose, this is the anterior ethmoid, this is the posterior ethmoid, this is the sphenoid, right? Here we can see the lamina papyracea. Let me mark it in blue. So here's the lamina papyracea. This is the cone of the orbit. This is the medial rectus, and here we have the lateral rectus. Here, can you see this? Let me mark it in another color. Okay, this is the orbital septum, right? So when there is inflammation and edema anterior to the orbital septum, that is in the eyelid, that is what is known as preseptal cellulitis. That is the first stage of the orbital complication. Now in preseptal cellulitis, what you will see is that there is edema and erythema of the eyelids, and when you open the eyelids, the orbit will appear normal. As you can see here, there is no chemosis, there will be no restriction of ocular movement, there will not be proptosis also as such, right? So here, also just note here that this is the sphenoid sinus here, and here what we are seeing, what is this? This is the cavernous sinus. So in preseptal cellulitis, there will be inflammation and edema anterior to the orbital septum. When there is inflammation and edema posterior to the orbital septum, right, that will be orbital cellulitis. So now let us see the rest of the stages. Now, whether it is the involvement post-septal, that is orbital cellulitis, or if it is in the next stages, abscess formation, whether it is a subperiosteal abscess or an orbital abscess, in all of these cases, orbital cellulitis, subperiosteal abscess, or an orbital abscess, patient's presentation will be more or less the same. Patient will have proptosis, patient will have restricted ocular movements. Yes. So how do we then find out which one is this, just orbital cellulitis or an abscess? Yes, so for that we go for CT scan. CT scan will tell us it is just a cellulitis or an abscess formation, and if it is an abscess formation, then our management can change to a drainage rather than just giving IV antibiotics. Yes, so then whenever we have the presentation like this, we like to go for a CT scan. And just see here, what will we see if it is orbital cellulitis? In orbital cellulitis, yes, it is known as post-septal or cellulitis or just orbital cellulitis. You will see the edema and congestion of the orbital tissues inside the cone. Now, if it is an abscess formation, yes, so if it is just adjacent to the lamina papyracea, there is lifting of the periosteum and there is collection just adjacent to the lamina papyracea, subperiosteal abscess. Yes, that will be an extraconal abscess pushing the orbit on one side. So this is the subperiosteal abscess, how it will look like. And how will be the orbital abscess? Then orbital abscess will be inside the cone, right? There will be collection of the purulent material inside the cone. That is how the orbital abscess will look like, right? So here we have some CT. Yes, so can you now make out here in this CT what it is? Yes, so what we can make out here is that this is again an axial cut section where we can see, yes, definitely there is proptosis. The anterior ethmoid, we have the posterior ethmoid, the lamina papyracea, the periosteum is raised, and there is collection here, and that is also pushing the orbit to one side, right? The same, exactly same we are seeing here, little collection, orbit pushed a little laterally, and also there is proptosis. So all this is subperiosteal abscess. Okay, so now also, yes, we saw that this here is the anterior ethmoid, the posterior ethmoid, this is the sphenoid sinus, and what do we have next to the sphenoid sinus? We have the cavernous sinus. So as an end stage of the orbital complications from the orbit infection can go to the cavernous sinus, leading to cavernous sinus thrombosis. Cavernous sinus thrombosis can be per se a direct complication of rhinosinusitis also without going through the orbital complication, right? So if I will show you this picture, this was one of the questions that was asked in your exam, and what was given was that the patient has features of proptosis. Yes, in one eye there is proptosis, there is chemosis, there is restricted ocular movement, and now in the other eye there is palsy of the lateral rectus. So what's the diagnosis? Is it orbital cellulitis or is it cavernous sinus thrombosis? So how do we differentiate orbital cellulitis from cavernous sinus thrombosis? Cavernous sinus thrombosis, because the cavernous sinus intercommunicate, cavernous sinus thrombosis will be bilateral. And to start with, it will be unilateral. Later on, it will become bilateral. And when it becomes bilateral, what will be the earliest finding of the other eye? Yes, it will be a palsy of the sixth nerve, the earliest nerve to be involved in cavernous sinus thrombosis, because this sixth nerve passes through the cavernous sinus. So it will be the sixth nerve. Later on will be involved the third and the fourth nerves, right? So in the other eye, what was the given in the question is lateral rectus palsy. Yes, that in turn is what? It is a sixth nerve palsy. So yes, whenever there is bilateral involvement and such presentation, you will mark the diagnosis as cavernous sinus thrombosis. Now, when I say subperiosteal abscess, yes, what comes to your mind is we have another complication, subperiosteal abscess, that follows frontal sinusitis, that is asked very commonly in your exam. Yes, and what is the subperiosteal abscess following frontal sinusitis? That present as a soft doughy swelling over the frontal sinus area, and that is what is known as the Pott's Puffy tumor. Again, very commonly asked, Pott's Puffy tumor. Pott's Puffy tumor. So, Pott's Puffy tumor is subperiosteal abscess of the area of the frontal sinuses, whereas there can be subperiosteal abscess following orbital complication also. There the subperiosteal abscess occurs adjacent to the lamina papyracea. Is that clear? So coming to the next question, a 60-year-old male presents with nasal lesion as shown in the image. Okay, so we are seeing some pearly mass on the external nose. Choose the most appropriate diagnosis: squamous cell carcinoma, basal cell carcinoma, inverted papilloma, malignant melanoma. So what do you think is the diagnosis? So whenever it is an elderly with some mass, pearly appearance mass or ulcerative mass also on the external nose, what is the first thing that we will think of? We will think of rodent ulcer. Yes, that is basal cell carcinoma. Most common carcinoma, if it is the carcinoma that we have to choose. So the most common carcinoma of the external nose as well as of the upper lip is basal cell carcinoma. Most common carcinoma, so here the answer is basal cell carcinoma. Most common carcinoma of the nasal cavity as well as the paranasal sinuses is the squamous cell carcinoma. In the paranasal sinuses, the most common sinus that carcinoma occurs is maxillary sinus. Yes, and inverted papilloma, what is that? That is the most common benign tumor of the nasal cavity. Malignant melanoma usually is a very rare tumor of the nose, but if it occurs, then usually there is melanin pigment appearing as grayish or blackish appearance that is usually visible, right? So yes, basal cell carcinoma, again, this has been very commonly asked, just the picture and the diagnosis. And also what is asked in tumors of the nose is the maxillary sinus carcinoma, the classification and the management. That is what you need to know there, right? Okay, so coming to the next question. Out of the four given statements, which is true about coughing? Forceful expiration against closed glottis, slow expiration against open glottis, begins with a shallow inspiration, removes harmful substances. Okay, so what is actually a cough reflex? Cough reflex, yes, it is a protective reflex to protect the lower airways from the harmful substances. Yes, last year was a question on the cough reflex that a patient has a foreign body in the inlet of the larynx and no cough reflex. Which nerve is involved in this patient? Yes, so what is the first step for cough reflex? The sensors of the larynx should sense that there is something abnormal. So the first step is the stimulation of the receptors, and these receptors then they send the sensations. The sensation is sensed by the sensory nerve of that area. So if it is of the supraglottis, what is the sensory nerve of the supraglottis? Yes, it is the, tell me, is the internal laryngeal nerve, right? So the first step is that the sensing occurs by the receptors and the nerve gets stimulated. What happens next is immediately the vocal cords open. Yes, the glottis opens and there is a deep inspiration. Following the deep inspiration, immediately the vocal cords are duct. They close, the glottis closes and the subglottic air pressure builds up. And also at the same time, the intrathoracic pressure immediately increases by the contraction of the intercostal muscles as well as the abdominal muscles by the pushing of the diaphragm. And that leads to a sudden forceful expiration against the closed glottis. And this forceful expiration against the closed glottis pushes open the vocal cords, and there is an explosive expulsion of the along with the foreign body or the secretions, and that forceful expiration, that expulsion is in the form of a cough. So these are the steps of coughing, right? So let us quickly see. So the first step is the receptorial phase, where there's stimulation of the cough receptors and stimulation of the afferent vagus nerve, right? Next is the inspiration phase, deep inspiration. And next, what happens is that there is closure of glottis that leads to increase of the subglottic pressure, and there is also along with that there is contraction of the muscles leading to increase in the intrathoracic pressure, and there is then the forceful expiration against the closed glottis, and that leads to finally the opening up of the glottis, and there is explosive leakage of air in the form of cough, right? So now let us see what is true here. There is forceful expiration against closed glottis. Is that true? Yes, that is true. Slow expiration against an open glottis. No, that is false. Begins with a shallow inspiration. It begins with a deep inspiration. Try to cough and see. Whenever you want to cough, how do you cough? There's a deep inspiration and then there is cough, right? Yes. So it begins with a deep inspiration, removes harmful substances. Yes, that is true. So what is true is 1 and 4. So yes, that is the answer. So yes, we have again a repeat question here, but the exact question is not repeated. Yes, we saw that this time the topics were repeated, not the exact questions. So the child has swallowed a foreign body. What is the nature of the foreign body as per the X-ray? So we have to see the X-ray and we have to see the foreign body, and it is given it is swallowed a foreign body, right? So it is clear where the foreign body is, but again, we will come to that later. So right now we have to see the foreign body. What are we seeing the foreign body? We can see some double appearance, some double density. So there is some halo-like appearance. Can you make out? There is some halo-like appearance, right? So yes, the halo-like appearance is the typical appearance of a disc, of a battery disc, right? So let us see what the choices are. Coin, disc, battery, marble, plastic piece. Okay, now out of these, the halo appearance is present only in the disc battery. The coin, marble, and the plastic piece will have a uniform appearance. And in fact, a marble will have it will be a little smaller, not a uniform flat-like appearance. Okay, so by the X-ray, we can find out this is a disc battery. Now, last year, what was given to you was a coin, and it was asked that where is it? Is it in the esophagus or is it in the trachea? So how do we find that out? Can you tell me that this disc battery is in the esophagus or is it in the trachea? So how do we find that? The longest diameter of the esophagus is the horizontal diameter. So if the coin or the battery or the foreign body will get lodged here, it will be like this. Whereas the longest diameter of the larynx is the AP diameter. So if the foreign body has got lodged in the larynx, it will get lodged like this, right? So on the AP view, if it is a larynx, you will see a rim. And if it is a lateral view that you are seeing in the larynx, you will see the round appearance. Whereas in the esophagus, on the AP view, you see the round appearance. On the lateral view, you see the rim appearance. So yes, this is in the esophagus. It is also given it is swallowed, right? So, okay, let us come to, can you tell me what this is? Can this be a disc? No, this is a uniform homogeneous appearance. So this is a coin. And this is, where is this? Yes, this is in the esophagus. No, this is not in the larynx. This one, yes, this when laterally when we see a rim. AP when we see the round, that is the esophagus. Now also please note here that what can you see here? We can see that there is a bi-leveled appearance. So this is how a battery will appear laterally, right? There will be a bi-leveled appearance. A step off at the edge. So is this, where is this? Yes, this is, yes, laterally you are seeing the round appearance. So this is in the larynx. This is in the larynx. Also please note here, if you are seeing this battery, right? And if I ask you, this is in the, yes, something else also you can find out, which is telling you, which is suggesting that this is in the esophagus. Yes, can you see the airway in the lateral view? We can see the airway clearly, and we can see that the foreign body is behind that. So these are the two things that you have to see to confirm that it is a laryngeal foreign body or it is in the esophagus. Now earlier also has been once a picture on the x-ray given of a coin, and what was asked was that how will you manage this child? Will you go for a esophagoscopy or will you go for a rigid bronchoscopy? So in other words, they are asking you, is this foreign body in the esophagus or is it in the bronchus or is it in the larynx? Yes, here this is in the larynx, so here you will go for rigid bronchoscopy. So the next question, a virus has a special affinity for stratified squamous non-keratinized epithelium. Which part is likely to get affected? Supraglottis, vocal cords, bronchus, trachea. So in other words, what is being asked is here, which has the lining epithelium as the stratified squamous non-keratinized epithelium? Yes, so can you tell me what's the lining epithelium of the supraglottis? Yes, so always remember that wherever there are secretions, the lining epithelium will have cilia to push the secretions, right? So if I ask you what's the lining epithelium of the nose, do we have secretions? Yes. So lining epithelium, ciliated, columnar, pseudostratified. Nasopharynx, again the same. In the larynx, in the trachea, in the bronchus, all these we have the secretions and we need cilia to push the secretions out. So yes, all these we will have ciliated, columnar, pseudostratified, except for in the larynx, the vocal cords. Yes, the vocal cords have stratified squamous non-keratinized. In the pharynx, if I ask you, the tonsils, they are lined by which epithelium? Yes, so all of the pharynx is by stratified squamous non-keratinized except for nasopharynx. The nasopharynx, the lining is same as the nasal cavity, and that is ciliated, columnar, pseudostratified. The lining epithelium of the tonsil, of the adenoid, very, very commonly asked. So tonsil is by stratified squamous, non-keratinized. Adenoid is in the nasopharynx. That will be by ciliated columnar. So which part is likely to get affected? So stratified squamous, we have, yes, the vocal cords. Vocal cords. So supraglottis is ciliated columnar, bronchus, trachea, all these are ciliated columnar epithelium. So that was the last question. And yes, as I told you, yes, these are the frequently asked INI-CET topics from the year. Yes, so please do them thoroughly before you go for the upcoming INI-CET. So from the anatomy, inner ear is the very favorite of INI-CET, the auditory pathway. And also in the middle ear, specifically the facial recess area, the anatomy of the posterior wall as well as the medial wall. And the inner ear, yes, very, very commonly. As audiology, we have very commonly tuning, folk test, pure tone audiometry, Bayer, and autocaustic emission is a special favorite. Serous otitis media, tympanic membrane retraction grace, tympanoplasty, squamous otitis media along with the complications, acoustic neuroma, autosclerosis, vestibular physiology, recently has been asked very, very commonly. There you have to see the nystagmus and hyperactive and the hyperactive conditions and the caloric test. The diseases of inner ear are favorite of INI-CET, mania, sudden sensorineural hearing loss, noise-induced hearing loss, superior semicircular canal dehiscence, perilymphatic fistula, and BPPV. Very, very important, right? And in hearing rehabilitation, very commonly asked is cochlear implantation and BAHA. Everything about these topics you need to know. Now, in the nose section, the anatomy, especially the lateral wall, the anatomy of the sinuses, the nerve supply and its anesthesia, very commonly asked in INI-CET. The arterial supply and epistaxis being an emergency, very commonly asked. Bacterial sinusitis and fungal sinusitis, of late allergic fungal sinusitis and invasive are very commonly asked. And the management of the bacterial sinusitis is also very commonly asked nowadays. So complication of sinusitis, rhinosporidiosis and granulomatous conditions, or out of the granulomatous conditions, the most frequently asked in INI-CET is the Wegener's. The tumors, the inverted papilloma and maxillary carcinoma, as I already told you, and the endoscopy, CT, and the X-ray findings, very, very commonly asked, right? In the pharynx, we have the anatomy, out of which nowadays the endoscopic pictures of the nasopharynx or of the hypopharynx are given, and certain structures are marked, and you need to identify. Angiofibroma has been an all-time favorite. Adenoids, tonsils, deep neck space, anatomy and its abscesses, and tongue is a special favorite. The anatomy of the tongue, the nerve supply, the carcinoma, the TNM staging, all that of the tongue is very, very important. Now, again, nasopharyngeal carcinoma also sometimes is asked. Now, in the larynx, we have the anatomy and the physiology, the nerve supply, the vocal cord palsy, very, very important. In the infections, we have the acute epiglottitis and the croup, very commonly asked. Their X-ray diagnosis, the management, very, very important. Carcinoma larynx is an extremely favorite topic. The post-laryngectomy, rehabilitation of olfaction, of speech, all this very, very commonly asked, and neck dissection and tracheostomy and foreign body of late has been a special favorite. As the INI-CET is again very close, it is natural and it is but obvious for thoughts of fear and doubt to arise in your mind. Yes, because I know it always seems almost impossible until it is done. So don't ever give in to these thoughts. Just have a lot of patience, have a lot of perseverance, and just continue doing what you're supposed to do in this particular moment. And take care of this moment. The future will take care of itself. I'm sure you're going to rock. All the best. God bless you.